Welcome. I'm Dr. Larry Tannenbaum, and welcome to RSNA 2024. We're live from the imaging floor, and I'm thrilled to welcome you to the Applied Radiology Roundtable series on the latest trends in Alzheimer's disease imaging and management. For this module, disease-modifying therapies in Alzheimer's disease and the role of quantitative imaging and AI, I am joined here by my former boss, Dr. Susie Bash, who is from RadNet. She actually runs the entire national imaging effort that RadNet has, and she's a medical director in the Southern California region. And it's a thrill to have you here today.
Thank you for inviting me.
Okay, great. So I know your areas of passion, some of them overlap with mine. Can you talk to me about how quantitative imaging fits into neurological evaluation, and then segue that with how it plays a critical role in Alzheimer's disease?
Sure. So I've actually been using quantitative volumetric imaging in my clinical practice at RadNet for the past 19 years. And our referrers really like this technology because it identifies and labels anatomic structures in the brain and then quantifies the volume of those structures. And then it allows you to have longitudinal tracking over time. And so, again, it really is very useful in the dementia landscape because it reduces reader subjectivity and tells you what's statistically significant for, for patient age and gender. And we know that patients that have memory loss, mild cognitive impairment, about 40% of those will progress on to Alzheimer's disease. And now that we have disease-modifying therapy available, what we really want to do is catch those patients at the very earliest stage. What we know from like the Clarity AD trials is that if you catch them early, like the low tau group, 76% will have no cognitive decline at 18 months, and 60% will actually have cognitive improvement. So quantitative post-processing tools can be very useful. So we know that amyloid deposition occurs like up to 20 years before the patient's symptomatic, but if the patient's brain volumes are still relatively well preserved, but let's say their amyloid PET is positive, so we're catching a patient with Alzheimer's disease, we know it's at an earlier stage because they haven't yet had volume loss. And so the quantitative tool can serve as a subclinical biomarker for disease state prior, and then the neurologist can go back to that patient and say, we think that you would be an excellent candidate for disease-modifying therapy, and in fact, doing much better than someone would respond if they were much later on in the disease. So it's taken on a new important role in screening, prior to starting the disease-modifying therapy. And, it also will play a role in detecting the potential side effects that you can get with these drugs. So unfortunately, with disease-modifying therapy, there's a risk of ARIA, which stands for amyloid-related imaging abnormalities.
Applied Radiology is not going to pay me for being on this program if you don't give me a chance to ask you another question. So I'm going to bring you back a bit, and then I'm going to let you go where you were going to go. So the first thing I would just like to say, let's take it back to a very simple, basic point of view. Talk to me about the role of MRI in Alzheimer's disease 3 years ago and the role of MRI where we are today. And then what are you actually looking for with your quantitative imaging that points you in the right direction that this might be an Alzheimer's case?
Yes, so basically, any patient who is a potential candidate for disease-modifying therapy needs to have a baseline MRI. And so it's important that for patients with memory loss that we have a consistent protocol for those patients. So we do what we call just a dementia protocol, and we obtain a 3D T1, at least at RadNet, on all of our patients that have memory loss. So
But you know that RadNet's practices are the world's best, right?
Yes, so it's really nice because then all of those patients will be quant capable. And we encourage our referring neurologists to actually utilize quantitative post-processing because now we have a baseline of what their brain volumes are. And we know that when patients have Alzheimer's disease, they can actually progress fairly rapidly off the normative curve. And this is a very objective way of tracking the volumes over time.
Okay, can I ask you to pause? I'm going to play panelist here, okay? And I'm going to say that traditionally, MRI is used to exclude surgical pathologies in patients with dementia, right? But now that we have disease-modifying therapies, it's important to recognize these patients, right?
Absolutely.
Can you get a little bit more into how quantitative imaging helps me get that recognition?
Absolutely.
And then perhaps segue into how we can use volumetric imaging to follow patients over the course of therapy, where you were about to go.
Right. So it's very important on the baseline MRI to identify if there's microhemorrhage present, and if there are, how many are present, because that will actually make it help the neurologist make a decision of whether the patient is a good candidate for therapy. So if they have cerebral amyloid angiopathy, and by the way, we know patients with Alzheimer's have a much higher incidence of cerebral amyloid angiopathy. Let's say they have 50 microhemorrhages, that patient is probably not going to be an ideal patient to put on disease-modifying therapy, given some of the side effects that you can get with DMTs. So that baseline MRI is critical to identify, how many baseline microhemorrhages there are. And it's also important to note other things, like are there strokes present, how severe is the microvascular ischemic disease? All of those things are important to know.
Part of the reason I'm excited to have you here today is to talk about my sense that there is a need for a call to action from the neuroradiology community to understand the unique needs of this patient population, both in terms of doing the scanning, follow up these scans, and what we need to look for, okay? And as you started to hint, is that once we've gotten into doing the MR and moving beyond excluding other pathologies, there's importance in making the diagnosis of Alzheimer's disease based on brain morphology, and that clearly, as you said, is dependent on accurate volumetric assessment of brain structures. But once they are now at the point of, say, having a PET scan, clearing the screening criteria for the MR, and do you want to elaborate again before I continue what the screening criteria are?
Right. So basically, for the baseline MRI, it's ultimately up to the neurologist about what they will tolerate on the baseline MRI. But in general, neurologists are not going to put a patient on medication if they've got a lot of microhemorrhages. So in the trials, it was, under 5 microhemorrhages. But in real life, again, there's going to be some flexibility. But if there's numerous microhemorrhages, again, probably not a good candidate. So a baseline MRI must be done, and that must be documented. And it also, the neuroradiologist needs to know if it's the baseline MRI rather than an ARIA surveillance MRI, because our wording in our reports is going to be quite different if it's surveillance versus if it's the initial baseline. So the baseline MRI is done, and then you have to prove amyloid pathology is present. So patients tend to like to get an amyloid PET. They could do CSF analysis as well. So both of those are used, either one of those are used, and then the neurologist would decide if they're a good candidate for therapy. And quantitative tools can be very useful. It turns out, if we'd like to move in to talk a little bit more about ARIA.
Well, I don't want to talk about ARIA until you tell me what ARIA is, okay? But I would say, as a comment in passing, is it seems like the volume of lumbar punctures for CSF analysis has dropped off precipitously when there was an amyloid PET as an alternative. And I think that's a very, very important piece. And I believe you established that you need an amyloid PET to establish eligibility, and that the fact that you actually are a patient with Alzheimer's disease. Can you tell me, why is there a unique concern in patients on these anti-amyloid therapies? What is ARIA? Why does it happen? How does it manifest? And what do we need to know as a neuroradiology community to do our job well and do the best service to these patients?
Yes, so any disease-modifying drug, well, actually there's 2 on the market space right now, but any of these monoclonal antibodies that target amyloid plaque can increase your risk of developing an amyloid-related imaging abnormality, which is ARIA. And there's 2 types of ARIA. There's ARIA-H and there's ARIA-E. So ARIA-H would be microhemorrhages or superficial siderosis that you can get in the brain, and ARIA-E would be vasogenic edema or sulcal effusions. It is absolutely critical that the neuroradiologist identifies this accurately, because the disease-modifying therapy has to be paused if the degree of radiographic ARIA is moderate or severe. And so it's very important for an educational initiative to train neuroradiologists on how to look for ARIA and identify it, and then communicate that effectively back to the referrer. So we've actually changed our referral pads at RadNet, so again, we can identify that.
One thing at a time here, because you're giving me so much information and I have a limited ability to process, okay? Let's go back to ARIA. You've defined what it is. Is it particularly challenging to see the findings on a scan? Is it something that all radiologists would be familiar with and just knock out? Or is there a need to focus on the specific needs of this patient population, report it in an appropriate way, detect it in an appropriate way? Again, we're talking about quantitative imaging today. Does quantitative imaging have a role in the detection, monitoring, and grading of ARIA?
It does, actually. And to get back to your first portion of your question, in one study, 84% of local radiologists actually missed ARIA initially, and that accuracy can go up if you use a quantitative tool. These cases of ARIA can be actually quite subtle. And computers are better at pattern recognition, and so they can take the QMRI tools. Will look at the baseline MRI and see if there's been a change on the ARIA surveillance MRI, and can actually identify that, color segment it, and measure it, and also give you the volume of change. So the QMRI tool can actually do the radiographic grading for ARIA for you, both for ARIA-E and for ARIA-H. So it will count the numbers of site that are involved, and in the volumetric burden, as well as the size. So again, when we're talking about ARIA-E, it's really more about size. When we're talking about ARIA-H, it's more about count. And so these tools will do this for you. And we actually polled the 6,000 members of the American Society of Neuroradiology, and the majority of the poll respondents said that they were interested in using a CAD tool, a quantitative volumetric tool, to help assist in ARIA surveillance.
Two things I want to discuss at this particular point. One is you've been involved with educating physicians on the subtleties, requirements, and obligations that go along with ARIA imaging. I'd like you to comment on that. But you also mentioned that a volumetric scan is part of the initial assessment, perhaps to classify a dementia, but also follow the course of therapy. Could you expand on both of those topics?
Sure. So, it's very important for neuroradiologists to have proper training to look for ARIA, to understand what ARIA is, and look for the radiographic features of that. So at RadNet, we have, probably 100 plus neuroradiologists. So what we did at RadNet is a training program that all of the neuroradiologists could go through. So I did a training webinar for ARIA, and people could watch that and get comfortable with what the grading system is. So I think really it doesn't matter if you're in outpatient or private practice or hospital based, it's important to have that training. And the ASNR also offers training, and so you can see cases. Again, very, very useful, because otherwise neuroradiologists prior to DMTs really were not familiar with ARIA. So an educational initiative is important there. There's also a need for educational initiative for interpreting the amyloid PETs that go along with this. And also we do an educational initiative for quantitative post-processing. So I did a training webinar for QMRI that our neuroradiologists could get to learn more about how we use quantitative post-processing, both at baseline and later on in the disease course for patients that are on therapy as well. But again, these quantitative tools for ARIA surveillance, I think, will be extremely useful for neuroradiologists.
Okay, I think we've really done a very good job getting that point out. I would just like you to comment briefly on one aspect, which is, what is the value of the volumetric assessment on the serial evaluations of these patients on therapy?
Okay, so it's an interesting point, because again, it's very important to know what their volumes look like prior to starting treatment. But a lot of most all of our neurologists, referring neurologists, will order QMI across the board for anyone with memory loss, which means that they actually can get QMRI as they come back for their ARIA surveillance MRIs. And what the clinical trials showed is that sometimes you actually get a drop in brain volume on QMRI after they've started therapy. And so the question is what causes that? And I don't think we know really 100% what does, but what has been hypothesized potentially is that the amyloid plaque itself takes up a certain volume in the brain. And we know that these disease-modifying therapies are very good at removing that beta amyloid plaque from the brain. So it may be that you're actually just removing a volume that was there when you remove the plaques, and that's why you see a slight drop-off on QMRI.
Okay, one last philosophical question. The drugs seem to work. You've cited some of the statistics. They have risks. You've cited some of those statistics. Other than that, what do you see as the headwinds to getting patients on these therapies? Are there any other obstructions to getting these patients infused and then imaged and followed up?
Yeah, so actually it seems to me that the headwind is actually not coming from the patient side. Patients actually really want to be on this treatment. And by the way, we didn't mention, but only 3% of patients are symptomatic if they develop ARIA. on Leqembi. It's about 6% for Kisunla, but it's a very small amount of patients that actually experience symptoms, even if they were to have it. And ARIA-E essentially always resolves, and then ARIA-H will kind of become stable over time. You'll still continue to see those, but the headwinds, I think, primarily are from the neuroradiology perspective, training people and training my colleagues and whatever in how to interpret these studies. But from the neurology perspective, there's a lot more headwind, and just because they're overwhelmed. It's, multiple studies that they have to order. They need to get back a good communication about whether ARIA was present before the next infusion can take place. So again, the onus is really on neuroradiologists to, number one, grade correctly, but number two, effectively communicate back to our neurology referrers to make sure that they get the image interpretation quickly and accurately so that they can make a decision about whether or not they need to hold therapy.
Yeah, I think that's a great point. We would ordinarily be ready to stop right now, but there's one thing that we didn't mention that I would really like to focus on. And as part of the call to action, we need to make sure that the imaging protocol is set properly for this patient population. We talked about the value of quantitative assessment, analyzing the T1 weighted images, which we would recommend would be a volumetric assessment. But probably the most critical finding that I have seen in my role as an enterprise manager in radiology is that the echo time on the gradient echo images is not set appropriately. Now, this is not just a symptom of places that are neglected. We see it at academic centers. We see it in the enterprise that I personally had to manage, and I'm quite disappointed to see that I didn't do it as well as I should. But you should know that there's a TE value that must be maintained to get the sensitivity that you need. Do you remember what that is offhand?
Yes, so on a 1.5, you would like the TE to be around 30, and on a 3T, around 20. And the problem is if the TE is too low, let's say it's at 5, you actually will miss the microhemorrhages. And so it is extremely important. So there's a lot of things that we did to adopt the practice, and you were integral in all of this. But to make sure that our protocols, all of our dementia protocols and the TEs were set correctly. So we want to make sure we get the 3D T1 so it becomes quant capable, and we want to make sure that the TE is correct as well.
Well, Dr. Bash, I'd like to do this for another half an hour, but this is probably a good point to wrap up our discussion on disease-modifying therapies in Alzheimer's disease and the role of quantitative imaging and AI. Didn't mention AI beforehand, but as you know, I feel AI is electricity. We don't have to mention it specifically. I'd like to thank Susie Bash from RadNet, really one of the great lights in this particular area, for joining me in this roundtable series on the latest trends in Alzheimer's disease and management, being hosted by our friends from Applied Radiology with kind sponsorship from both Siemens Health and Ears and AgoraCare. Dr. Bash?
Thanks for having me.